Khan to present to us on glaucoma diagnosis that is important to miss. Dr. Khan there?
Yes.
Yeah.
Yes, can you see my screen?
Yes.
Yes.
And you can hear me? Yeah.
Yes.
Sure.
Okay. Okay, thank you, Dr. Sarendrar. Thank you, Dr. Agarkar and the AIOS and the Asia Pacific Society for including me in this meeting. It's a pleasure to be participating and talking to you about a glaucoma diagnosis we should not miss. Now, I think we're all familiar with primary congenital glaucoma. Increased intraocular pressure in infants causes physical changes to the eye. And on the basis of these changes, we can pretty easily diagnose primary congenital glaucoma. But there are some conditions out there that look like primary congenital glaucoma and actually aren't. And there's one condition I'd like to highlight because I've seen it misdiagnosed as primary congenital glaucoma too many times. And this is a glaucoma diagnosis we should not miss. It's exemplified by this child. He's a 3-month-old boy referred to me for glaucoma surgery. He's tearing, he has photophobia, he has high intraocular pressure. The corneas are large with haze. He has a myopic reflex, difficult to quantitate, and it's difficult to see the posterior pole. He's just so uncomfortable. This certainly seems like glaucoma. I don't like to take these children to surgery until I get a good outpatient exam. So he was very uncomfortable. I put him on a combination beta blocker carbonic anhydrase inhibitor to get his pressure down a little bit and to examine him again before taking him to surgery. It certainly seems like glaucoma. And when he came back, I was quite surprised to see that he was much more comfortable. The corneas had cleared. The corneas were large, but there were no Habe stria. The IOP came down to 10 from almost 40. He had high retinoscopy reflex. He was highly myopic, but the fundus did not look myopic. And there was no significant cupping. So the pieces of the puzzle here are not fitting together for primary congenital glaucoma. And we look at him more carefully, you can see here that he has a large cornea, but he has lens subluxation, spherophakia. The lens is actually anterior. He was getting intermittent pupillary block because he has a unique phenotype that certainly exists in the Gulf region. I know it's in India as well because I've seen cases in India. This is a unique phenotype of primary megalocornea. It's not a secondary megalocornea from high intraocular pressure. It's a primary megalocornea with zonular weakness and lens-related secondary glaucoma. It is critical to recognize these patients and not confuse them as primary congenital glaucoma because doing angle surgery on these children is disastrous. The treatment for these children is the lens has to come out. So this condition is caused by mutations in a gene LTBB2. Again, these patients have a primary megalocornea and the lens moves forward and they get a secondary glaucoma. But if you're looking at them quickly and in the heat of the moment, they're easy to misdiagnose as primary congenital glaucoma if you don't look at them carefully. And it is a disaster when they have surgery as primary congenital glaucoma patients. This gene LTBB2 is very interesting. It interacts and resembles fibrillin 1. Fibrillin 1, of course, is the gene that when mutated causes Marfan syndrome. These patients do not have systemic manifestations. These patients have an ocular phenotype. It's written in the literature that LTBB2 mutations can cause primary congenital glaucoma based on these two studies, but unfortunately, this is incorrect. In these two studies, there were 4 Pakistani families, 8 European Gypsy families, and 3 Iranian families who were diagnosed as CYP1B1 negative primary congenital glaucoma. CYP1B1, of course, is the gene that most often is associated with primary congenital glaucoma. These patients had been diagnosed as primary congenital glaucoma, were negative for CYP1B1 mutations, had further analysis, and were found to have LTBB2 mutations. And on this basis, LTBB2 was associated with primary congenital glaucoma. However, if you look at these papers, many of these patients were examined only later in life, at which time they had corneal scarring and advanced disease. And it was assumed that they had had glaucomatous damage from primary congenital glaucoma, but they really had end-stage phenotypes. Also, many of these children in the original studies had documented ectopia lentis and responded poorly to angle surgeries in childhood. I've since spoken to these authors. It's very clear now that these patients didn't actually have primary congenital glaucoma. They had this unique phenotype: primary megalocornea, zonular weakness, secondary lens-related glaucoma. The lens has to come out. Angle surgery is a disaster. In the end-stage phenotype, it can be confused with corneal scarring and buphthalmos, because the cornea is enlarged primarily. That can be mistaken as buphthalmos if you don't see them carefully at an early age. In 2011, I was at an ARVO meeting and I was presenting something, I don't remember what, and it was about this time I was understanding about LTBB2 mutations. I wasn't presenting about LTBB2 mutations, but the person next to me, it was a Japanese group, they were talking about an LTBB2 mutant knockout mouse, and they were doing that study because LTBB2 had been reported as a primary congenital glaucoma gene. And I was delighted to read their paper because I was standing right next to them. In their mouse model, they found only fragmented ciliary zonules and no evidence for any problem in the trabecular meshwork. Very consistent with what I'm telling you. Mutations in LTBB2 do not cause primary congenital glaucoma. They cause this unique phenotype that can be mistaken as primary congenital glaucoma. This is the first child I ever encountered with this disease. Actually, I didn't see him at the time this picture was taken. I saw him later when he had almost Tysical eyes. This is a picture from the other ophthalmologist who diagnosed this patient as primary congenital glaucoma and did bilateral angle surgery. Actually, they put in Ahmed valves because they were afraid of severe buphthalmos. In fact, he didn't have primary congenital glaucoma. You see those huge corneas, but there's no stria. It's impossible to get huge corneas like that from primary congenital glaucoma without a stria. You can also see the corneas are very clear. Unfortunately, after he had his bilateral glaucoma surgery, he developed bilateral lens luxation into the posterior chamber and bilateral retinal detachment. Angle surgery is disastrous in these patients. Here's a 5-year-old child who came in with the lens in the anterior chamber. Now, when the lens comes in the anterior chamber and they have a pupillary block with the lens in the anterior chamber, it's not a problem. We know the lens has to come out. The problem is when the lens is behind the iris and it's causing an intermutant pupillary block. Again, look at the size of these corneas. These are 13, 14 millimeter corneas, no stria. This eye, the lens is subluxated. It's hard to see in the picture. This is the LTBB2 phenotype. Again, when these children come in, they can come in as infants with the lens in the anterior chamber. There's no question what the management is. The problem is when they have the lens behind the iris and it's causing intermittent pupillary block. This 6-month-old was going for glaucoma surgery for primary congenital glaucoma. He was going for goniotomy. Thankfully, we were able to intercept it and do the appropriate surgery, which was removal of the lens. This is LTBB2 related primary megalocornea, zonular weakness, and secondary lens related glaucoma. Now, let me go back to this first case that I presented to you. The 3-month-old, he had no cupping at the time. He was a -26 refraction because of the spherophakia and anterior lens movement. He was getting IOP spikes. I explained the situation to the parents and scheduled the child for lensectomies. Unfortunately, the family didn't like what I told them and they decided to go elsewhere. And they came back to me 2 years later, and it's quite a sad story because they had been all around town. They had been to many different ophthalmologists, and they basically had multiple angle surgery, which all failed. the lens dislocated, eventually the lenses came out. Now he truly had glaucoma because of the inflammation from all of the surgeries. He lost one eye, he's now monocular. It's a very sad case because had the lenses been taken out at 3 months old, he would have been fine. And that's my experience with these patients. If you get them the lens out early, it solves all the problems because the primary problem is the lens bouncing up against the iris. So to summarize, I've highlighted to you this glaucoma diagnosis that is important not to miss. Primary megalocorneal lasagnular weakness. Those of us who take care of childhood glaucoma need to be aware of this diagnosis, examine our patients carefully. If we do a careful examination, we won't miss it. But if there's corneal haze and we just go for angle surgery, assuming that we have primary congenital glaucoma, we'll get in trouble. These patients, one of the clues is they have huge corneas, but no hypstria. You don't get a 14 millimeter cornea in an infant from primary congenital glaucoma without some hypstria. So thank you very much for the opportunity to participate today.